Welcome to Homecare Connection, brought to you by the VNA and Hospice of the Southwest region. I'm your host, Harry Snyder. As you know, November is National Hospice Month. For more than 27 years, the VNA and Hospice of the Southwest region has been providing person-centered hospice care to residents in our community in the comfort of their own homes. Here to tell us a little bit more about the hospice program is Nicole Moran, the Director of Hospice and Palliative Care, Anastasia Mattsson, a registered nurse who works in hospice, and our hospice chaplain, Father Andrew Carlson. Welcome to the show, everybody.
Thank you.
So it is National Hospice Month, so perhaps we can just start talking about what is hospice as a general term. What is hospice?
I'll answer that.
Okay.
So hospice is a special type of care designed for patients and families who are facing a terminal illness. It's a interdisciplinary approach to care where the patients are provided services by a team of clinicians. So not just nurses, not just social workers, but including chaplains, spiritual support, bereavement support, volunteers, aides, and other therapies as well, with the whole goal of being providing comfort and quality of life, and working with the patient and family to identify what their goals are for their end of life. How do they want to spend what time they have left? And so everything is centered around the patient and the family and those goals that are identified.
And are there eligibility requirements? Are there specific types of people who are eligible for hospice, or
Yes.
is that not a?
Yes, there are specific eligibility requirements. A physician needs to certify that a patient has a terminal illness, and that means a physician will say that the patient has 6 months or less to live if the disease follows the normal prognosis. However, that doesn't mean that at the end of 6 months that we discharge people off of hospice. We have patients on for a lot longer than 6 months, and we have patients on for a lot less than 6 months.
Right.
That's just a general guideline that we're held to by the regulations. And the terminal illness has to fit certain criteria. So a cancer patient has to meet certain criteria. End-stage heart failure, end-stage lung disease. We can admit people for a lot of different diagnoses, and there's different criteria for each one. And we kind of tell physicians and family members that let us kind of deal with that piece, and we'll figure it out from there.
And that makes sense. I mean, I think historically there has been some misconceptions around that
Yes.
hospice is only for people who have cancer or something like that, and that's really not the case, right?
Right. I mean, originally, when hospice became a Medicare benefit in 1983, it was the majority of patients on it were oncology cancer patients. Now it's about 50-50. We have about 50% of our patients have a cancer diagnosis, and then 50% have a mix of other things. So like I said, heart disease, lung disease, renal failure, stroke, Alzheimer's disease, a lot of different diagnoses. So it's a much mixed blend now of patients.
You know, we'll probably work our way to and from the next question I have, but you know, one of the things I think it would be important for folks to know about is you know, is there sort of like a right time to ask about hospice? Is that something that people talk about? Is that?
Yeah, I think we're a lot better about talking about it more routinely now as a culture. Generally, people don't like to talk about death and dying, but I think we're getting better about starting those conversations sooner on in disease processes, which is great. We don't want it to be the elephant in the room. We want people to have those conversations so that their wishes are honored up until the end. So is there a right time? I don't think there's a right time for anybody. I think it's individual to the patient and the family and the circumstances that they're in. You know, what I would say is that don't ignore the topic and bring it up whenever you feel it's appropriate.
No, and I appreciate that because recently I had a close family member who had been declining over an extended period of time. And really, up until just days before she passed away, she just sort of couldn't wrap her head around the word hospice.
Right.
And I think that, you know, what I found interesting about that, just on a personal note, was that before I started working with hospice, as a program, I might not have had the insights that I did, but being able to have that conversation, and then in the last few days that she was alive, she was on hospice, and she was with her family was around her, she was kept comfortable, and I think that's something that perhaps is also worth talking about a little bit, is that there does seem to be a particular philosophy to hospice, and maybe that is something that you guys can talk a little bit about, maybe even within your own specific areas of work, because that is something that is probably unique to each person on the interdisciplinary team. Is that not fair?
Yeah, absolutely, and I'll let these folks chime in, but just to, an overall perspective is that the philosophy is symptom management, comfort, quality of life overall. But what do you guys think as far as your specific, as from a nursing perspective, Stacy?
I think from nursing perspective, hospice is about the now, the here and now, and that the patient is still living, and that we do like to focus on the fact that they're living right now, and that it's not all about the end of life. We do like to try and get people earlier so that we can help them in a longer period of time to be there and give them the supports and allow them to do things they might not have been able to do without extra support from our team.
Well, and on that note, you had said that the part of the eligibility requirement would be a diagnosis that would indicate 6 months of life or less. But the fact of the matter is that once our hospice team is actually in a patient's home, it is in fact possible, because you guys do focus on quality of life, that they do live longer than what was initially expected at the time of diagnosis.
Yes. There's actually studies out there that show that patients who, two patients with the same diagnosis, one on hospice and one not on hospice, that the patient that signs on to hospice will actually have a longer life expectancy because of the symptom management that we do so well, and that they're in their own homes.
Right.
I mean, people thrive in their own homes.
Absolutely.
Nobody does well in the hospital environment. I mean, it's a great thing to have when you need it, but people do much better in their own home where they're comfortable, they have their family, they have their pets, their surroundings that they're used to. They're eating their own meals, that says a lot.
I mean, I'd say that we go in just as much for the family as we go in for the patient themselves. When we have a chance to go in and work with all of these different people, there's really wonderful opportunities for healing, wonderful opportunities for things to be said that have needed to be said, in some cases for years. And that the chance to have individuals within families themselves heal is really quite tremendous. I mean, as you pointed yourself out, Harry, that when you're a family member of someone who is substantially ill or dying, that the experience belongs to you too, and not just to the patient. And that's one of the other things that hospice, I think, really works hard to do. We try to make it an experience for everyone who's there.
And I think, again, if when you are a family member, one of the things that I think is true, and again, maybe that's part of the reason why the hospice team is designed the way it is that family members, don't start grieving just after the death.
Right.
Actually, the grief process starts quite often before.
Well, and it's different, and it's
different
not to interrupt you, but it's,
right.
it's different.
It's okay.
It's different for every person.
Right.
The way I would go through the stages of grief might be very different from the way that you would, or anybody else for that matter. And there is no normal. I mean, there's healthy and there's unhealthy.
Right.
But that's what this team is trained to recognize, is that
Right.
people are going to pass through these stages at their own pace. They may take 4 steps forward and then 2 steps backward.
Right.
And that's why we provide such great care to the patient and the family, because they have that. These clinicians have that training to recognize those situations.
And maybe we can talk about that a little bit, because I mean, so each of you provides serves a particular role in the hospice program. And in fact, as you said at the opening, Nicole, it's a team, an interdisciplinary team. In fact, it's actually called that, right?
Yes.
IDT, interdisciplinary team. If when a client comes on to hospice services, I mean, maybe you guys could talk a little bit about sort of what that experience looks like, either individually or as a group. I mean, what is it? Because there is a full team approach to hospice care, yeah?
Absolutely. Absolutely.
I'd say the only thing that's predictable is that it's unpredictable.
Yeah.
I'd say under most circumstances you would have a nurse, an RN, go out to do an admission, and that individual would sit with the patient and with the family and take all the substantial clinical information about a person's illness, the progression, what's been going on. But we have had circumstances where it doesn't run that way. And I've had a circumstance on a couple of occasions where there's the family member in crisis who is having substantial difficulty dealing with just the idea that a family member is going to be going on hospice, because for that individual, hospice equates with death. And it's wonderful when we as a team can go in and you see this look of relief and enlightenment when people realize, oh, it's not just about someone dying, but it's about improving the quality of life when people are there. And we have experiences like that all the time.
Yeah, I think it's about relationships too. If we didn't have a big team, I think it would be very difficult for one person to manage. We have to have the team. I'm often telling families, you know, I'm here for the patient, but I'm here for everybody in this room also. And for our own personal needs also, I think we need our team to help us get through some of even for our own grieving processes. Patients also grieve way before those final days, and that's a lot of work we go through, is the loss of just basic things, the loss of being able to drive or even just go to your doctor's appointment on your own and manage that. There's so much involved that the team really pulls a lot together, I feel.
You know, we speak a lot to, you know, the interdisciplinary team, and that there are all these services that are provided to patients on hospice. With that being said, though, not everybody needs all of that support. I think one of the great things about the hospice benefit, which majority of our patients are on Medicare. So the Medicare hospice benefit identifies that some patients are not going to want home care aides, physical therapy, chaplain services, all of that. Some patients might just want or need a nurse at once a week. The flexibility of the benefit is great because we can increase, decrease services as needed. So in the beginning, when somebody signs on to hospice, they might only see their nurse once a week. And then as things change and maybe they become more ill or need more support, we can increase those services. So the nurse might be going every day towards the end, and then adding the aid services and the chaplain services and all of those things, as you know, the support needs to be strengthened as things start to kind of disintegrate, we'll say. We don't want that to happen, but we recognize that sometimes it does.
Yeah.
And also, one of the most valued services that we provide isn't represented here today, and that's our volunteer services. We have a whole host of volunteers that go in for a variety of reasons. It might just be to spot a caregiver so they can get out and go to the grocery store. It would be a chance to read. We've had circumstances where individuals a patient who speaks German, we have a German-speaking volunteer, and they've been able to talk. Plus, we have a whole bunch of other things that our volunteer services provide. I'd say perhaps the most enjoyable one is a program that we have that's called Dinners with Love, and it involves having major restaurants in the area provide meals that will go out to patients and a family member on a weekly basis. And people will usually be on a 2-week rotation where they can receive a meal. Whether it's having a person come in for respite care or Dinners with Love, or our choir, which is called Trillium, which comes in to sing to folks, it's really about doing small things. And one of the remarkable aspects about hospice care is that people begin to remember how important the small things are.
Well, and again, I think to that point, perhaps the biggest misconception about hospice is because in order to be eligible, there is a diagnosis of a terminal illness. And Anastasia, you said it earlier, I mean, this really is about what's happening now. This is about actually the life that is in the present. It really isn't about death. And it sounds really like every aspect of the hospice program is focused on sort of that celebration of that life in the moment. And that's pretty powerful. Now hospice patients, are they generally seen at home, or are there any restrictions on where hospice clients can be seen?
Majority of our patients are in their own, what we call traditional home.
Okay.
That could be a skilled nursing facility, an assisted living, but majority of them are in a private residence. We do take care of patients in the hospital in special circumstances. If someone has symptoms that we cannot control at home for whatever reason, we do have contracts with the hospital here in Rutland and our hospital in Bennington to send patients for some short-term symptom management with the goal of sending them back home. And just another little aside is a lot of people think that once you sign on to hospice, you can never go to the hospital, you can never go see your regular physician anymore, and those are all myths. We actually encourage our patients to continue to have that relationship with their primary care provider if they so choose. We want them to be part of the care team. They know those patients the best. And then also if they need to go to the hospital for something not related to their terminal illness, for example, a patient who has breast cancer is on hospice for that. If they fall and break their hip, that doesn't mean that, oh, you're on hospice, you can't go and get your hip fixed. Medicare recognizes that there are special circumstances that they can do that. And we work very closely with the hospital. Our medical director is Dr. Alan Eisman for hospice, and he is part of the cancer center as well at the hospital, and he works very closely with us, and he's a great resource. We're very lucky to have him as our medical director.
And you know, I think that point is something that does bear just a bit more focus on, because the fact of the matter is that so many people in this country have multiple conditions that can impact them over the course of a lifetime. The disease or the illness that qualifies somebody for hospice, they could have comorbidities, is that the right word? That go along with that, for which they can actually receive treatment, ongoing treatment for. And that is important because, again, I think it comes back to the hospice philosophy, right? Which is comfort, and that it is about maintaining that quality of life. So if things are interfering with quality of life, then the program acknowledges that at its core and says, you know, we can help coordinate that care as well.
In fact, I'd add that this idea of quality of life doesn't end with the patient's death. It goes on in terms of doing work with people who are grieving afterward. One of my major jobs as the bereavement coordinator is that I work with families who have lost an individual and who are dealing with the aftermath of that. And I will see individuals on an individual basis. We also run a grief group that meets in town, meets weekly all throughout the year. And we also have, which will be coming up, we have an event every year called the Tree of Remembrance, which is an opportunity to remember people who have passed away in the last year. So we take, I would say that the hospice movement not only takes the patient who has the illness very seriously, but also takes the aftermath of what happens with that seriously, and we follow people for 13 months afterward.
And I think that is something that my understanding of that concept of hospice is that it's tied into the idea of how people process grief, and so those, whether a hospice patient is on services for a day or for a year, the bereavement counseling services are afforded to those family members for, like you just said, 13 months after the death of the.
And that's not hard and fast. We will sometimes I'll have a phone call come in from someone who might have lost a parent or a child, say a couple of years ago, and it's coming up on the holidays and they're having a difficult time. We're not going to turn a person like that away.
No, I appreciate that. Do we have enough information yet to talk about the tree remembrance just for a minute, or?
We do. So it's Tuesday, December 5th
Okay.
at the Franklin Conference Center at the House Center in Rutland. The event starts at 6 p.m. There are mailings going out to, I think, the last 2 years of our patients and their family members with the invitation. And it's an opportunity to remember their loved one.
Yeah.
It's a really nice event, and it's around the holidays when a lot of people, that grief, as Andrew said, comes back to the surface for many folks. So it's a really great opportunity to remember those loved ones that have passed on.
That's great. Yeah, December 7th, you said?
December 5th.
December 5th. So December 5th at the House Center?
Yes, at 6 p.m.
Great. I mean, and that is something that if somebody was interested, they could either respond to the mailing or call the agency.
Absolutely.
And we'll give out the information about how they can contact us at the end of the show. But
That's right.
I do think
cookies.
Cookies and singing, right? The Trillium Singers are always part of that. No, it is first couple of years that I worked here, I attended the tree remembrance ceremony, and it is really to see people. There's a lot of honest emotion, and it's just a real. It's actually happening. You can feel it when you go to it. It's pretty cool.
Yeah.
And you know, I think that it behooves us to touch on another aspect of hospice, which maybe is related and yet also separate, and that is and tied to your title, because your title is Director of Hospice and Palliative Care. The idea. So I'll ask a quick, simple question: what is palliative care?
So I like to always tell people that hospice is palliative care, but palliative care is not hospice.
Okay.
So that same holistic approach, interdisciplinary care that we provide with hospice is the same care provided to patients on palliative care, but those patients are maybe a little bit earlier on in their disease process. They may still be seeking treatment. I don't think I mentioned this earlier, but one of the eligibility criteria for hospice is, yes, you have to have that terminal diagnosis, but the patient also has to be willing to focus on comfort and quality of life, and not desiring treatment or cure anymore.
Yep.
So with palliative care, those patients can still be seeking treatment for their disease process, and they might not be at that terminal position yet.
Right.
But it's the same approach to care. It's family, patient-focused, identifying their goals, what's important to them, and helping them, see where they are today and get them to where they want to be tomorrow.
And one of the things I think, right, that is true about our palliative program is that, generally speaking, the same nurses that work in hospice also work in palliative care. Is that?
Yes, our palliative nurses are meant to try and, if you transition to hospice, you're not switching your team. You have the same team, so you have a ground base. Some people don't want to go into hospice, and others choose to vary further into their diagnosis. I think it just makes it easier for them to have the same team that they're working with. So
it provides a smoother transition.
Yeah, I would think.
When people are ready for hospice, that continuity of care, I think, is really important at that stage. The other thing that we do with palliative care is really focus on end-of-life decision-making. Many people have not done an advance directive.
Right.
Many people don't even know what it is.
Right.
So helping that patient and the family identify what their goals are, putting them on paper, designating an agent that could make decisions for them if at some point they're unable to. We see so many people that have not done this yet, and that's so important. I always tell people, you want somebody to be able to make a decision for you if at some point in your life you can't do it yourself. And what's important to you? What do you want? And what don't you want as far as treatment options are concerned? So we do a lot of work surrounding that.
And that's done by the hospice staff?
With the nurse and the
staff?
social worker,
Okay.
primarily the social worker.
Yep.
But the nurses have those conversations with patients and families all the time.
I think we're often starting that conversation and leading it over to the social worker. It's definitely her skill.
Well, and that makes sense, because the social workers probably by trade are the folks who connect people to those support services that sort of fill in.
Absolutely.
And social workers are a part of the interdisciplinary team. are they
Yes,
not?
for both
Very much
hospice and palliative care. Yes.
Now, is there a difference between the services that a patient is eligible for under palliative care versus under hospice care?
Slightly,
Okay.
not much.
Yeah.
The two biggest things I think with palliative care is they do not receive volunteer services like Andrew was
Okay.
speaking to earlier, and they also don't receive spiritual support or bereavement support.
Okay.
So they seem like two minor things, but as far as the grand scheme of things, they're huge.
Yeah.
You know, being able to access that bereavement support 13 months after death is really a great thing to have access to. But we also recognize that there are some palliative care patients that might not ever transition to hospice for whatever reason.
Sure.
And we do case by case provide bereavement and spiritual support and
Oh,
volunteer
okay.
support.
Yeah.
It's not every patient,
Right,
but
right.
we do that.
Well, and again, I think it you know, if I may, the theme that I think just keeps coming through in every aspect of whether it is palliative or hospice care is this is a really individualized, patient-centered model of care that focuses on comfort, and the nursing services, the focus is on comfort, and I'm guessing that as a hospice nurse, there's probably your work day or your responsibilities don't necessarily end at 4 o'clock in the afternoon. Is that a fair statement?
No, people choose to die whenever, so we are 24/7. There's always a nurse on call. I think that's helpful that we're not in the home 24/7. They always have access to a nurse.
Right.
So we try to be very available. We don't want any family to feel they're alone in this process. So being available for people is really important, and that goes for the rest of our team. We, if I need to get a hold of Andrew at 3 o'clock in the morning to do last rites, he's, available. Shauna's very available, so I think having that team and knowing that there is somebody there for them, even if it's just a question or something that they feel is benign, we're still very much available for them.
And so sometimes those calls can actually just be a phone call, but sometimes there's
sometimes
home visits as well,
it's
right?
just a phone call. It's just needing a little reassurance
Yeah.
of what's going on with the patient's behavior,
Yeah.
or it's a medication question, just not sure what I'm supposed to give, when I'm supposed to give.
Yeah.
Other times we do need to go out. The patient might be going through a situation that they actually need a nurse at the home, and we will go at 3 o'clock in the morning on Christmas Day if you need us. So it's important.
Well, and one last thing I'd like to talk about before we break is related to, the family members of hospice patients receive education as well, do they not, as part of the caring of that patient?
Absolutely. As patients begin to decline, family members become a very integrated part of our team in taking care of the patient and helping just with basic daily needs, making sure patients' mouths are swabbed when they can't swallow. So we're always teaching to families and patients and whoever's willing to be there for the patient at that period of their life.
And again, I'll just come back to it. I just think that when you start to think about what it means for a patient to be able to be at home with their family, and then their family to actually be able to provide that kind of support to a family member has got to be something that really not only adds value to the patient's life, but absolutely to the family members' lives.
I think our overall goal is to empower family members with all the tools and resources that they need so that they can feel proud of the care that they've provided for their loved one.
Yeah.
And that's the key, and that is the backbone of hospice and what we do every day.
Pretty much just a different way of saying exactly the same thing is the one thing that every one of us on this team is focused on is about maintaining and improving the dignity of the patient and their family. And when a good day is when an individual, no matter how ill they are, is reminded of the fact that they matter, or that the family is reminded of the fact that they matter, and that's a good feeling.
Yeah. Well, listen, I know it may be hard to believe, but we're out of time. Thank you all for being on the show today. I just think that as we get information out about hospice, it is something that can really make a difference in people's lives. And I thank you all for coming on the show and also for doing what you do every day for folks in their homes. That is all the time that we have for today. But if you want any additional information about the hospice or any of the programs that the VNA and Hospice of the Southwest region offers, you can call us at area code 802-775-0568 or visit us on the web at www.vermontvisitingnurses.org. I'm Harry Snyder, your host, and I'll see you next time on Homecare Connection.